The content of this presentation is the challenge we face from a practice point of view, but also from a policy point of view. How do we get proven interventions into routine practice, and particularly how do we get higher levels of population prevalence and reach for those proven interventions? So fundamental questions to effective research translation, there are many of them, but key ones that we need to have answered are: what are efficacious interventions in terms of reducing prevalence of risks? And critically, what are the interventions that are effective in achieving widespread implementation of those proven interventions? And I'll term that implementation research. But critically also, from a practice and a policy point of view, we need to understand what's the relative gain and the relative cost of different implementation approaches. There isn't a single approach that we need to assume exists for us. So in terms of what implementation evidence is available to us, Serene Jung, one of the members of our team, this year had a paper published where Serene undertook a review of trials in the Cochrane Library by translation stage. And as you can see here, only 2% of those trials in the Cochrane Library dealt with implementation dissemination, and the rest were, in a sense, efficacy-based trials. So there's not a lot of evidence we can draw upon if we're going to be evidence-based in terms of implementation science. What's the evidence to draw upon to scale things up? A very similar sort of study was done by Andrew Millat a couple of years ago, looking at the types of studies, looking at physical activity research and how they're classified. And of those studies, a very similar pattern was evidence that 86% of the studies were efficacy and only 3% were dissemination focused. So again, focusing more on obesity prevention, the evidence base for informing what we do in terms of translating proven interventions in policy and practice is pretty scant. So implementation is an issue for us. We need to strengthen the evidence base to identify what it is we need to do. It's another reason why we need more implementation focused research, because the limited information that's available suggests that if you take a proven intervention and proven under a controlled research environment, efficacy studies, you get an effect size estimate which is double that if that same intervention is put into place into the real world under real world conditions. So there is something in the translation, if you like, from efficacy to implementation that we are losing effect size. So if we run on the evidence-based mantra that let's take efficacious trials and we should roll that out as routine policy and practice, unless we apply some science to that rollout, we are not going to get the hoped for benefits from those efficacy studies. Not only does implementation per se evidence is it required, but also we need further evidence about different implementation approaches. This is a graph which indicates a particular program, child obesity prevention program, which has been rolled out across primary schools across New South Wales. This graph shows the implementation of the Crunch and Sit program as certified across the Hunter New England Health District since 2008. You can see here we began at a baseline of 20% in 2008, and last year we got to 80% of schools were certified for that program. The equivalent data, which is not shown on the graph, but in 2014 the proportion of schools across New South Wales that were certified for Crunch and Sit was 40%. So what this graph then shows is that there's a particular implementation approach which is adopted in Hunter New England realised a beneficial greater prevalence of adoption than the approach implemented across the state. So that's the challenge for us. How do we get better evidence? What's the evidence base to support maximum change and, importantly, maximum reach across any given population? A particular implementation challenge we face in New South Wales is the adoption by schools of the government's Fresh Tasted School policy. Currently, the data suggests that 15 to 30% of New South Wales primary and high schools are compliant with that policy. It's been in place for quite a number of years, and there have been small changes and increases in prevalence of adherence by canteens to the policy, but there's been small changes and there's been slow gradual improvement, despite considerable investment and an extended period of time where the policy's been in place. So what we did, we wanted to, from a local health service point of view, we needed to decide how best to implement the Fresh Taste policy, how best to encourage schools to adopt it, but what investment did we need to invest and what return on investment we would get in doing so. So we've undertaken a number of 3 randomised controlled trials to look at different implementation intervention strategies to see what effect the variability intensity would have on adherence by schools to the policy itself. The outcome measure was canteen menus without any red items for regular sale, and the outcome measure was through dietitian reviews of menus. We had 3 intervention approaches. One we'll call intensive support, which involved approximately 2 FTEs of support staff per 35 schools to support schools to take up the fresh taste policy in their canteen. The intervention lasted for 1 year. The intervention was a multi-strategic practice change intervention based on the literature around practice change, involved executive support, consensus processes, training workshops for staff, site visits, resource kits, menu review and feedback, and certificates of recognition. Optimal intervention, if you like. The next intervention was low support, which was approximately 1 FTE of support for 35 schools, again for 1 year, and a much simpler single strategy approach, which audit and feedback of the canteen menus up to 4 times in a year. The third intervention is what we've called here a non-targeted intervention. Across New South Wales there is a large-scale program called the Healthy Children Initiative. It has a focus, it's a whole of school child obesity prevention program. It seeks to have schools adopt up to a dozen different policies and practices, one of which of those policies and practices focuses on the fresh taste policy. So it looks at not changing many aspects of the school canteen as one focus of that. And those 3 intervention studies used a no intervention control group of schools which obtained their canteen information from a variety of other sources, but the primary source of that information was the Healthy Kids Association, which provides online and other resources and information to primary schools. So the results of the different trials, the high intensity you can see here went from a baseline of 4% of schools were adherent at baseline through to 76% at follow-up. The low intensity moved from 3% to 36% of schools. The non-targeted canteen intervention went from 7 to 14%, all increases in absolute terms. There was a non-significant change in the non-targeted canteen intervention. The low intensity intervention is wavering around 0.05% significance, and no effect in the no intervention control group, where the schools on a more passive basis obtain their information from a variety of sources, but primarily the Healthy Kids Association. We looked at the cost per adherent canteen. You can see here it was roughly $4,500 for schools to become adherent to the policy receiving the intensive intervention. Slightly less cost, $3,900 for the low intensity, and total cost for the HCI initiative was $19,200. But if you was to crudely divide that by, say, 10 of the different policy and practices it was focused, it would reduce the cost for a canteen component down to roughly, say, $2,000. That's a crude approximation. We can't attribute the whole of the HCI cost to this result. So the conclusions from that is, in terms of effect size, achieving increase in adherence is possible, fairly clearly. There's a strong dose-response relationship in terms of the intensity of intervention. The greater the change occurs with the greater intensity of support. And it appears that the increase in adherence requires proactive practice change support, not simply passive information resource provision. If we look at reach, similarly achieving a high population prevalence, assuming 75% as a target of that, achieving that is quite possible. Again, similar profile of results. A higher prevalence of adherence is associated with greater intensity, and higher reach appears to require proactive practice change support, not simply information resource provision. And in terms of cost, the highest cost is for the highest intensity of intervention, predictably. So in terms of the meaning and the usefulness of this information for evidence and policy and practice, the findings of scale of practice change are consistent with implementation research findings from other settings. The bulk of the implementation science research findings sits in the clinical practice space. However, the effect sizes we have here, particularly around the intensive and the low intensity of interventions, appear to be greater than what we've found in the clinical practice implementation science literature, Cochrane reviews, and significantly greater reach in terms of those changes. The policy and practice implication relate always to what is the objective of the policy and the practice. If the objective is to increase adherence and to maximise reach, the audit and feedback intervention, if it remains significant, may provide the best value for money, but it's only marginally better value for money compared to the high intensity intervention. And if policy and practice objective is to inform and provide resources to schools regarding fresh taste, just a simple information provision objective, then information resource provision on a passive basis, no intervention may provide the best value for money. Thank you very much.